So on the majority of neuroendocrine tumors, regardless of their site, they have what's called hormone receptors on their surface. And think of them as like a lock of a door, for example. And we know that these locks or receptors is where the somatostatin drugs, such as sandostatin, octreotide, or lanreotide, for example, bind to the surface of those net cells and cause those net cells to either stop growing, decrease in size, or decrease hormone production. But we can also use those locks to our advantage because we can actually bind the hormones to a radioactive atom, such as lutetium. And what that does is these net cells bind the octreotide or lanreotide, and attached to that is a radioactive atom. The cell gobbles up the radioactive atom and therefore causes like a little nuclear explosion within the cell and kills the cell off. And that's called peptide receptor radionuclide therapy, or PRRT. And we've been doing PRRT for patients with NETs for the last 20 years or so. And it's also obviously run across all the major NET centers across the world. And we've seen very good prolonged tumor control, whether it's stabilization of disease or whether it's a decrease in the size of the tumors for up to 3 or more years in patients with NETs. And we now have what's called a randomized phase 3 trial called the NET-1 trial, which randomized patients with grade 1 NETs to PRRT versus higher dose of octreotide if they had progressed on standard dose octreotide, and found that PRRT did provide a better tumor control, much better tumor control than the control arm. So that's become now a universal standard across the world, and it's been funded by the Americans and the Europeans, and hopefully we'll get funding for that in Australia. But we're still doing that as part of our standard therapy in Australia. But that only accommodates those patients with the low-grade NETs, the grade 1s and the low-grade 2 NETs. What about those patients with the higher grade 2 NETs or the low grade 3 NETs? These are the more aggressive tumors which tend to grow very, very quickly, and we've often previously had treated with chemotherapy. And at Peter Mac, as well as some European centres, have been treating these more aggressive tumors with PRRT, either as first-line treatment or patients that have had prior chemotherapy. And we often see in these patients that when we do a GAT8 scan, which I know majority of your NET patients do have, that their disease, especially if they're well differentiated, grade 2, grade 3, the GAT8 scan shows all their sites of disease up, and therefore tells us that we can actually target these diseases with the radioactive therapy. And we have seen very, very good responses and disease control compared to, say, chemotherapy alone or drugs like everolimus, for example. Probably not as long a control as, say, compared to those patients with lower grade disease, but again, much better than standard chemotherapy, for example. So we initially put up a submission to one of the companies that makes PRRT about doing a trial in grade 3 NETs, and they subsequently took on the idea and developed the idea. So now we have the COMPOSE phase 3 trial. It's a randomized phase 3 trial, being that we're randomizing patients to either PRRT alone or to the best standard care, subject to the doctor's own opinion at the different centres. And the standard of care would be either chemotherapy, such as oxaliplatin 5-FU called Folfox, or capecitabine temozolomide, or everolimus. And these would represent standard regimens for this type of disease. And so patients either have 6 cycles of PRRT, subject to their response, versus ongoing chemotherapy or everolimus. And it's for patients with high grade 2 disease or low grade 3 disease. They may have had 1 prior chemotherapy or prior octreotide or lanreotide therapy and show disease progression. And it's for patients whose disease is almost entirely avid on the GAT8 scan. And if some patients for this trial also need to have an FDG PET scan, which shows more aggressive disease. And most of those FDG adhesions also need to be GAT-AG. So we're basically targeting all sites of disease with the PRRT. I think that's an area of active research for our NET patients. We have been combining chemotherapy, whether it's capecitabine or capecitabine temozolomide, in PRRT for patients for a prolonged period of time. And I think the evidence is mixed about whether we should be or should not be. I think it really comes down to very careful patient selection and think about it in the high-risk patients. And we certainly do that as routine. And there's now more trials looking at careful selection of high-risk patients where we would add chemotherapy. We're certainly at Peter Mac running a trial called the PRRT trial, which Grace Kong is leading, and we're adding a drug called a PARP inhibitor, because we know that the way that radiation works is it damages the patient, the DNA or the genes within the NET cell, and the NET cell can't repair that gene and dies. Some NET cells do repair the genes and continue to live on. And so with this PARP inhibitor, what it does is stops that DNA being repaired, therefore increases the damage of the DNA by the radiation from PRRT. So we're actually now having what's called a phase 1 trial looking at different doses of PARP inhibitor in combination with PRRT. And there's also other studies looking at combining other biological agents to PRRT, and including immunotherapy as well. And there's certain discussion within international groups to try and develop trials of immunotherapy with PRRT also.